دكتور وائل حضرتك
Okay, all right. Hi, good afternoon, everyone. It's welcome to our course on Vitreoretinal routine business. This is Ahmed Salam from Arkansas, USA, and I would like to welcome my friends and guest speakers, starting with Dr. Wael Awais from Egypt. Wael, welcome.
Hello, welcome, Ahmed. It's my pleasure.
And my dear friend Abdullah Laban from Hull, UK. Well, Abdullah, thank you very much for joining us. And my friend and my dear friend Wael Soliman from Asyut.
Hello, Ahmed. Hello, everybody.
And our friend Mohammed Tawfiq from Egypt. Mohammed, thank you so much for joining us.
Thank you, Dr. Salam.
And Dr. Ahmed Habib, and he's joining us from Alexandria, Egypt. So he's he might be maybe he's not having very good connection there. And also at the end of the course, we'll be interviewing and getting my senior resident in, Don Chancellor, who's a resident and moving to a fellowship in Baylor soon. Okay, we'll start with Dr. Abdullah Laban speaking about macular hole. Abdullah, tell us what you have on macular hole.
Hello, good afternoon, everyone. It's my pleasure to be here with you today. So I'll speak quickly about macular hole surgery, and I'll try to make everything simple. I'll show you some few tips for the surgery. Just before the surgery, when I see a patient with macular hole in the clinic, I spend a couple of minutes in the clinic doing some measurement for the hole. And actually, I record all my macular hole surgeries. In the UK, it's one of the benchmark standards for the performance of the vitreoretinal surgeons. And I also look for whether there is a BVD or not. It may be a good tip here to see in the scan, when we see an operculum, in the OCT scans, this means that the hyaloid remains attached. So it means it detached from the macula, but remains attached in the disc. So I prepare myself to induce BVD during the surgery. Fortunately, macular hole surgery, more or less, the technique is the standard, mainly vitrectomy combined with ILM beal and gas, plus minus cataract surgery if you prefer to do so. In my practice, I always try to do combined surgery when possible, if the patient is phakic. I just do simple surgery. I'll just try to do small incision when possible. And I stress on cleaning all the viscoelastic behind the IOL. And once I finished, I try not to hydrate the wound at all. And then I put my infusion. Whether you do 27 gauge or 25 gauge, essentially the same. Sometimes in our practice, we have this nice plate haptics IOL, which is a really good IOL, especially if you do a combined surgery. The good thing is that it doesn't depend on the capsular exercise. It's very stable with posterior segment manipulation. And you can do it through a very small incision. And once I do the IOL, I'll just for all junior colleagues, just make sure you check the infusion before putting it on. Sometimes in a busy day, you may go quickly and miss this step. It's really important in all cases to strictly check your infusion. And this is the whole surgery. In my practice, I usually start 3-port vitrectomy. Just do very gentle core vitrectomy. And after completing the core vitrectomy, I prefer to use the stain. Nowadays, I nearly use a stain to stain the posterior hyaloid in all my cases. I just stop the video here for a few seconds. Just notice that I just let the stain to dribble. I try not to force it. So just trickling the stain. Sometimes this gush, or if you inject the stain under high pressure, sometimes this may cause retinal trauma.
Abdullah, let me just interrupt you here. So have you ever had a complication where the cannula slipped off your hand as you're injecting something inside the eye?
Not in my case, but I had one colleague mention, not even the cannula, even the gush of fluid under high pressure itself could traumatized the retina.
So make sure you really hold the cannula very well. You're going ready to shoot and get it dribble from distance. Right, Abdullah? Yes, thank you.
Yes, I'll show you this step again. Actually, just let the stain dribble, trickle down, just very gently. Don't push. And I nearly use the stain nowadays for all cases for BVD induction. I found it really helpful, and I already will use the membrane blue in all cases. So after that, I go to the BVD induction, and I use the vacuum. I'll stop here. I usually try to use the BVD in stages. So if you have noticed here, I just induced the BVD, but didn't go all the way through the wave. So partially detach it from the disc, and then I'll encourage it in other quadrants, but I don't usually tend to take the wave all through to the front part. After completing the vitrectomy, again, trickle the stain for peeling the ILM. I'll just try to wash all the stain as much as possible, but I try not to take a long time in that, so to maintain the ILM well stained. After removing the stain, in my practice, I usually use a forceps, and I usually try to do a very gentle bench, just to get an area, an edge of the ILM. Once I get the edge, I follow the edge all the way through the macular rhexis. I often aim about 3 to 4 millimeter macular rhexis, and all the way through, I try to grip from the edge.
Abdullah, what lens do you use here for peeling?
In our system, we use the IBOS lens.
So that's a non-contact system.
So the IBOS system has a wide field lens, often called XL lens, and often has another high mag lens called 90D lens.
Sure.
So I'll just only one bench per case, and often try to do it either superior temporal or inferior temporal. I become very careful when I reach near the pupillomacular bundle, often hold from the edge, and I'll try as much as I can to make sure that the ILM peel is complete at the edges of the hole. So here it's not complete yet, still a small piece, and attach it to the whole edge. Yeah, here you can see a complete peel of the ILM at around 3 to 4 millimeter in diameter. This is another case. I'll go quickly through it, same way, let the dye dribble. And sometimes these dyes actually has a high gravity, so they usually settle on the macula. And here I started inferior temporal, just only one bench. One bench, I got the edge now. So then I follow this edge all the way through about 3 to 4 millimeter. Sometimes you have to regrip a few times, but again, every time you regrip, just to grip from the edge. Don't do any other benches, because even if the bench is very gentle, this can cause trauma to the superficial retina. And when I do the peel, I stress that the area around the hole is completely peeled. So you can see here still some of the ILM attached around the hole. See, I'll try to hold it again, hold the flap again, and make sure that the macular rhexis is complete.
Abdullah, can you move on to the next steps for the sake of time?
Yeah.
Thank you. I mean, your point is very clear on the peel.
After peeling, I'll do just some further peripheral trimming. I don't intend to do complete vitrectomy, just very gentle trimming of the peripheral retina, and I'll do 360 search like for all vitreoretinal surgeries, making sure that to check for any peripheral retinal breaks. In my practice, I tend to use C2F6 gas 16%, but there are many other options for gas SF6 or C3F8. The gas injection is very straightforward. In our practice, we use a 50 ml syringe. We usually use C2F6, so we fill it with about 8 ml of C2F6, and then we mix the gas. I usually connect it to the infusion to one of the ports, and I tend to remove the two superior sclerotomies and massage them, make sure that they are sealed very well. And then I start injecting the gas, and I usually vent with a 30 gauge needle. So here's the gas is coming in, and the vent is through the needle. If you have a 50 ml syringe, this means that you will flush the eye at least 7 or 8 times. This ensures that you get the correct amount / concentration of the gas you want during the surgery.
Right. That's very good.
Yeah.
Yeah, thank you, Abdullah. That's very good. So, Abdullah, I've got a few questions for you.
Yeah.
Let me just share my screen. Or actually, okay. What will you do if the hyaloid separation is difficult? So macular hole, usually when we operate, even if there's some vitreous separation on the OCT, clinically there's no PVD. So usually you induce the PVD as you've beautifully shown. What would you do if you really trying to induce the hyaloid separation, but it's difficult?
Yeah, in some cases, it's sometimes very adherent, especially if you use 27 gauge. The grabbing force of the 27 gauge is very weak.
So what do you do?
Sometimes they use a pick. So you can use a sharp pick connected to active aspiration. And I prefer to stain in these cases. Once I stain and I use the pick and try to make a plane. Once you make a plane and you induce the active aspiration, the hyaloid partially detach. And sometimes the fluid wave inside the eye induce further PVD.
And well, Suleiman, you used the same technique in diabetic. You showed us a nice video on this, right?
Yes, but I never use a pick without putting triamcinolone, because if you put triamcinolone, you can delineate actually which is attached and which is not attached. So it's risky to use a pick without staining or for doing BVD.
That's a very good only, yes. A nice video on also on the ophthalmic surgery page about the pick as well, if anyone wants to see. So Abdullah, you've detached the hyaloid, but the hyaloid is really stuck at the arcade. My question is, would you insist on detaching it and maybe risk an iatrogenic tear and just deal with it, or you would leave it and just leave it?
That's a good question. Actually, I usually do limited vitrectomy. I don't chase the hyaloid. Once I induce the BVD, if it reaches the equator, that's good enough for me. And I just do very gentle trimming for the peripheral gel. Again, the pathology here is mainly at the macula. There's no need for extensive vitreous-based shaving or peripheral trimming because I feel macular hole is a simple surgery. I'll try to keep it simple. I try not to chase the peripheral vitreous, otherwise I induce a break and this will need lasers or cryo. So I often try to keep it simple. And actually, with our simple technique, fortunately, our success rate is very high. I guess we have about 93 to 96 success rate in primary macular hole surgery with such simple technique.
Thank you, Abdullah. That was my next question. So my last question on the macular hole to you should, before a technique, use little gas because maybe there are cost implications. Abdullah practices in a posh area in the UK, so he doesn't worry much about money. But can you tell us about how to use little gas?
Yeah, I inject the gas through a separate needle, and I abolish completely the infusion cannula. I remove the hole chokers, insert the gas in the syringe as if I'm giving an intravitreal injection, not with a higher concentration than the almost double concentration. This is so simple. For example, SF6, 2 centimeters diluted with another 3 centimeters of air. This makes 40% SF6. This is double the concentration that is required. Injected into the air, which is already filling the vitreous cavity at the end. It becomes diluted to half the concentration, by 50%.
Right. Thank you, Ed. So, the volume of air, if you fill the eye with air, it's like 4 cc of air in the vitreous. If you inject, let's say, 1 mil of 100% SF6, then you're making this 4 mil 5 mils. So that becomes about 20%.
Put in mind that the 4 cc of air will turn down to 2 cc once you remove the infusion cannula. So when you inject a higher concentration of the gas, it will fill up the gap.
So it's a very there's slightly like some not certain calculations, but it's just a good way of using. Yes, I think there's some noise in the background.
But
just one second, if you don't mind, there's some noise in the background. So if we make sure the Facebook is off or YouTube, and also if we can mute, unless you're asking any question, and I'll do that myself as well.
So.
Question from
about the inverted flap, Dr. Abdullah. Do you have a cutoff width of the macular hole that you after which you do the inverted flap technique?
So for primary macular hole surgery, I just do a macular excess. I don't do any flaps for
whatever the size.
Sorry?
Whatever the size?
Whatever the size. I often try with just simple technique. If the hole is a little bit large, let's say, when I mean large, at least more than 600 or 700 micron, I sometimes, with the edge of a soft tip, I just slightly massage the edges, so to make the hole a little bit smaller on table. This encourages a lot of the healing with the primary surgery. And I also advise the patient for strict posture. Even I may admit him one day in the hospital, just to make sure that he follow the posture instructions. As you know, most holes usually close within the first 48 hours, actually.
So quick question. So does anyone do ILM flap for large holes? Can we have just a quick answer or a show of hands? Ahmed Habibi.
Nearly always.
Man as well. Anyone else? And Dr. Okay. So again, well, Oasis as well?
I do ILM flap for all macular holes, even if it's small macular.
Okay, so we have the different techniques here. I do like Abdullah as well. I keep things simple for primary surgery, and I do like Abdullah. Okay, we'll have to move on for the sake of time. Again, if you can please all mute unless the person speaking. And our next speaker is Dr. Wael Awais, and he's speaking about epiretinal membrane Wael. And we will all mute.
I think I'm having a problem with displaying the PowerPoint, the keynote, I'm sorry. Mohammed, would you please rapidly show me how to get rid of the green spot?
ممكن تفتح الباوربوينت بتاعتك يا دكتور وائل، يعني كان open الباوربوينت now. Open بس الباوربوينت.
Well, just open your keynote. We can see it behind.
Keynote. Just open now your keynote. See, يعني دوس على أيوة and just open your keynote and it will be fine.
Can you see it now?
Yes. Make it full screen.
Yeah.
Okay, perfect.
Okay.
Yes, you're good. Yes, we can see you. You're good.
I will start directly with something remarkable. The tools that we used for the epiretinal membrane peeling, I am using somewhat something different from what Abdullah uses in the macular surgery. I prefer to use a macular contact lens because, as you see in this short video, it provides me with a better stereopsis and a very high magnification, which provides me with a great deal of dexterity and versatility while peeling the membrane. This is the first point. The second point is that I like to use chandelier illumination as a default illumination in all the vitreoretinal procedures, including the macular surgery. The chandelier gives better illumination, and I have my both hands free, and I will show you how it helps me a lot during the macular surgery. For example, well, let's start first with the vitreous. The posterior hyaloid in epiretinal membrane, of course, we know that in about 85% of the cases have already PVD. But in case they don't have a PVD, I like to induce, whenever possible, the PVD without using triamcinolone. But if it is not enough, I would use the triamcinolone. but this is not an essential step. The essential step is the injection of the beryllium blue G stain in this case. And the point is, what am I going to stain? The BBG will stain the ILM, not the epiretinal membrane. So in the epiretinal membrane, I will depend on the concept of negative staining. The area that is not stained and appears grayish is the area that will be the epiretinal membrane. How to inject the stain? I have a somewhat different technique. I ask the assistant to switch off the infusion cannula so there is no turbulence of fluid, and I go too close to the macula. With my cannula, I hold it with one hand and I inject with the other hand. So in this way, I am controlling that nothing would slip, no extra gush of fluid would happen, because I am controlling well with one hand. The second hand is holding the cannula, and the right hand, the working hand, is injecting the stain in a controlled fashion, as you see. And I wait for 20 seconds. I count from 1 to 20, and then we reoperate again the infusion and we wash out the stain, preparing for the membrane peeling itself. If the membrane is thin, it is relatively more difficult, but I try as possible to start even at the edge of the membrane. And I go in a circular fashion, because I expect in these cases that the ILM will be peeled off because it is attached underneath the epiretinal membrane all through the journey. But after the peeling of the epiretinal membrane, I re-inject again, double staining. Why? The double staining here, for example, in this case, it helped me. I will show you with the arrow here with my pointer. There was a residual epiretinal membrane in this area. And I am sure now that there is no residual ILM underneath. This is important because this residue of epiretinal membrane will be the starting point for a reproliferation later on, the recurrence, which may happen again. So in this way, I am trying as possible as I can to minimize the possibility of having a recurrence of the epiretinal membrane. And I try to go as wide as possible to make a wide area of the macula without epiretinal membranes or ILM. The thick epiretinal membrane is relatively easier. This is a traction of diabetic macular edema due to a thick macular pucker. You will see here that I could easily grasp the gray area, which is the membrane. It is very thick, and it was very easily pulled off the macula. But are we sure that there is no ILM behind? Look, after the restaining, I found that there is a complete and almost complete sheet of ILM. And that's why it is usually important, in my opinion, to do a re-injection, double staining in these cases. This residual ILM I manage as routinely. I grasp with the ILM forceps at the edge, and I try to peel in a circumferential pattern. Once there is a flap, it is very easy to re-grasp the membrane again and to move as possible as I can and as wide as I can with the peeling. Of course, the contact lens produces a limitation in the field, but it helps from another point. I usually like to keep the case at the end under air because there is no macular hole. It is just that I want to fill up the globe with air to seal the sclerotomies from inside. It has a better sealant property than to leave it in a fluid-filled eye, or at least to make a partial fluid air exchange. This is a simple approach to the macular pucker. And thank you.
Well, thank you so much. This is fantastic, Reed. So I have a few questions. So you peel the ILM routinely as well, right? So you restain and peel the ILM routinely.
Yes, I do this in epimacular. Should I stop the sharing?
Yeah, I think fine if you can stop the sharing. And my second question is, okay, sometimes, some cases, even on the OCT, the fovea is very thin. Do you do anything different? Do you try to spare the foveal peeling when the fovea is very thin?
No, actually speaking, I use instead a Thanos scraper in some of these cases in myopic.
Right.
myopic eyes, yes, I may use a Thanos scraper at least to fashion the flap. If the membrane is thin and the fovea is thin, I would definitely start at an ILM point, not at the. I may not find the epiretinal membrane clearly. I will depend on the ILM, which is properly stained with the brilliant blue G. I will make my flap as if I'm dealing with a macular hole until I find the epiretinal membrane peeled off on my way when I'm going in the circumferential fashion.
Right. And question here to Dr. Wasser Emanuel. So when you have a lamellar hole and the fovea is thin with the ERM, do you do anything different? Do you worry much? Do you spare the fovea?
Yes, I spare the fovea. I try to do circumcision of the ILM around the very thin fovea, and I leave this part. So I didn't peel above the fovea. But I should depend on the OCT before I start my operation. So you just look at the OCT and starting the operation. One thing also that I always aim at the beginning to remove the ILM, as Dr. Well said, and I stain first, do removing of the epiretinal membrane, stain again, and if remnant, I remove as Dr. Well said. But fovea sparing is very important, and this depends on the OCT.
So again, so let's. There's a bit of echo, so if we can switch off in between. So the microphone. So again, we're targeting starting surgeons. So just be very wary, especially when the fovea is thin. Just be very wary. Try to spare the fovea. Even if you leave a little bit of epiretinal membrane attached to the fovea, it's not going to harm anyone. But
you can leave it. You can leave it.
Yeah, but as long
you
as
can leave it.
And last question, really, for for the last case, for the last case, you showed a diabetic one. I have two questions.
Yes.
First, in this case, were you able to separate all the hyaloid, or the hyaloid was stuck down because of the previous PRP?
No, I had first to separate the posterior hyaloid to induce a PVD. This is not a primary idiopathic epiretinal membrane. It has a different property because in the diabetics, we expect always that the posterior hyaloid will be there in place. I managed this in the beginning, but I didn't show it in the video because I was
focused. Were you able to separate it fully? I'm sure. Were you able to separate it fully or no?
Yes, I could separate. Yes, yes.
I could have been better.
I think because I'm sorry for interrupting, because usually the beginning of a posterior vitreous detachment, I usually depend in about 90% on the probe, but there is a trick to use a high vacuum and to stay stationary for a while. Don't be in a hurry to pull. Just hold and keep holding as if you are building up vacuum within the probe itself, and try to move gently and slowly until there is a threshold, like the boiling of water. At a point, you will have it all grasped with you and to go up anteriorly. With
if it's not coming up and you can see the retina tenting, would you stop and leave it, or you would insist on?
Yes, of course. I would stop at a tenting in a diabetic case because I expect in this area that there might be a point of old vascular epicenter. Hyaloid in diabetics, of course, we need to manage very cautiously in comparison with an idiopathic case.
Yeah.
Iatrogenic breaks and hemorrhages are very liable if there is a point of attachment.
Habib, do you concur?
Yes, that's a very nice trick about about staying still over the disc while attempting to remove to induce the PVD. In the era of the small gauge cutters, that's very important with the 25 and 27. I think you should induce very high vacuum and stay still for some time to get a good grasp, because that was not a problem in the 20 gauge era when you just pick it up and go away. So that's not the case with the 25 gauge and 27. So I would like to stress on this tip and trick. It's a very nice trick, and it usually succeeds in inducing the PVD.
Thank you so much. That's actually a great tip. So I tell my fellow to go down to the edge of the disc, stay there, push all the way down, and count 1, 2, 3 before you start moving. So, Mohammed, do you want to get ready with? Yes, please. If you have any comment, and if you want to get ready with your presentation as well.
I need I have two questions, Dr. Wael. If you decide your surgery about ERM, is it an OCT decision or a type of ARM decisions, whatever it's idiopathic or diabetic? And second question, is it mandatory to remove all the ILM in ERM surgery or not? Whatever you're doing, double stain or not. So if you remove your retinal membrane, and again, you are staying and you see the
That's the first.
Well, Dr. Mohammed, concerning the decision making, I don't depend on the thickness of the membrane, or whether I depend on the OCT, whether it shows there is a real traction or not. Okay, if it is a thin membrane with no underlying traction, of course I wouldn't touch the patient. But if there is a traction, it doesn't make a difference whether it is a thick or thin. The technique is almost
whatever it's idiopathic, whatever it's a diabetic, whatever the type or the cause.
Yes, because maybe in the diabetics, I am a little bit cautious, and I try to do in some cases where the membrane is very thin, and I don't feel that it is the real contributing factor. A case which I cannot consider as a frank, true tractional diabetic macular edema, I give a test of intravitreal anti-VEGF. If there is no response, so this is a traction, and I will go for the surgery.
Very nice.
The second point in the question. The ILM. Well, I usually have a point of view in surgery. If I am there in the vitreous and on the macula, and there is a possibility 5% of a recurrence of the epiretinal membrane if I leave an underlying ILM, so why not to peel the ILM in the surgery, better than to leave the patient with an ILM and he gets a possibility of recurrence later on. I mean, I like usually to do as possible as I can, so long I'm not harming the patient, so long that the ILM peeling is not risky, does not jeopardize the safety of the retina.
Well, thank you. Well, we have a question here from Dr. Wael Al-Tahan. So what's the cutoff point of vision? So let me just give a small introduction, which has been a point of emphasis recently, that many patients have terrible ERM, but they have very good vision. So we are operating on the vision and the vision need rather than the OCT. So, Wael, what's your cutoff point? Do you have any cutoff point?
Yes, I think that the vision is had better be less than 0.5. I mean, 0.4,
612, right? 612.
Yes, 612 is my. I consider myself very impulsive if I operate on 612.
Right, and I'm sure really we've all operated on better vision when they were very symptomatic. So, question to the panel from Dr. Mustafa Hanout from Canada. Dr. Mustafa, regards. So, do you all peel the ILM? Can we have a quick reply just for the sake of answer? We'll start with Dr. Habib. Do you peel the ILM routinely in ERM?
Yes, I do. However, I don't believe it's that necessary, but
right.
I usually do.
Tawfiq?
Yes, I do.
Yes, I do. Okay, well, Suleiman?
Yes, I do. Yes, I do.
Okay. And Abdullah?
I do that in selective cases. Sometimes when you peel the ERM, the ILM comes with it.
No, sure. If it doesn't come, so how, like 50?
If it doesn't come, I check the macular profile. If the macular profile looks fine and well, I don't tempt to peel it. If I'll feel some distortion, some a little bit of subtle changes on the macular surface, I may consider peeling it as a separate step.
Okay, I do like Abdullah. I have also intraoperative OCT, so I get an intraoperative OCT scan. If it looks fine, then fine. I try to do the minimal required. So I do like Abdullah. And again, a message for all junior trainees showing us, just do the minimal required until you're up and running. And then after that, you can have your own perspective and you know your limitations. Question here, I think we've answered that question from Dr. Khaled Husseini about the full thickness and lamellar macular hole. So lamellar macular hole goes under epiretinal membrane, and they are repaired mainly if there are significant symptoms based on the vision. Okay, we'll move on.
Lamellar macular hole, it's a visual acuity-based decision, not an OCT-based
Yes,
decision.
especially that results are not robust. You may end up with full thickness macular hole, so you need to be wary. So I think that's a very good point from Dr. Tawfiq. So I would lump it under the ERM, and maybe it's a visual acuity rather than OCT decision. Does anyone have any different view about lamellar holes before we move on for retinal detachment?
Yes, there is another point, not only the visual acuity, the metamorphosis.
Yes.
Yes. Symptoms, you mean symptoms.
Yeah, absolutely. Okay, Mohammed, I got your video here. No, sorry. Okay, here you go.
Okay.
I'm sorry. Okay, here you go.
Okay.
Okay, Mohammed, you're on.
You are in now?
Where's Mohammed Tawfiq? Yes, we got your video, Mohammed.
Yes. This is a case of primary pneumotogenous standard detachment. My usual technique in this case is also, and all my cases now is doing 4-port vitrectomy. The visual side of my trocars is in 10 and 2 clock hours, and the infusion cannula is in lower temporal quadrant, the chandelier in lower nasal. This is my preferred site for chandelier. Starting with anterior vitrectomy, I think we can do this step without going by your biome. Just show a shine of your vitreous, and if you are very confident that you are completing your vitrectomy or removing your all vitreous, almost in 90% of these cases, after finishing this step of anterior vitrectomy, I think you can feel that you are finishing your all vitrectomy, you are removing all your vitreous, because in most of these cases there is a total posterior hyaloid detachment. But be very cautious to go prefer or to go much more without visualization, because in cases of polus detachment, you can bite your retina.
So Mohammed, this is a good way also of like testing your system, right? Testing that the cutter is working and everything is well, and clearing the view as well, right?
Yes.
Yeah.
Perfect. Also, I didn't stain usually in myopic or usually pneumotogenous standard detachment. I didn't stain triamcinolone, even only in cases of high myopia, or I am feeling that I am not confident that the posterior hyaloid is totally moving. As you can see here, I found the primary break. I doing a fluid exchange, make the retina make the retina flat, and again I found another break, one upper and one lower. First, this is a critical step for me to release all vitreous attachment over the break. This is the most what's called pathological vitreous here in this eye. You must remove all vitreous attachment over the break, and also I clearing the break from this anterior flap. So remove switching the horseshoe tear to a hole, and then after I'm very confident that I remove all my vitreous. I didn't care to be very meticulous to remove all the vitreous base, but as much as I can. I didn't stop at this level. I need to be indented also the retina 360, because there is maybe a missed break over at some area. As you see here, I trimmed the anterior flap. Any folded retina, any folded edges like this, I try to trim it, and I therm the breaks. For me, this step now is not a critical step in the area of visualization, but also if you are put yourself in a safe zone, please therm your breaks. Starting indentation here is not for complete shaving, but it's for searching for any breaks. As I'm indenting, I complete vitrectomy and shaving as much as I can, but not very meticulous to complete to remove all the vitreous. But as you can see here, when I indenting, I see a very small hole. As you can see here, if I'm not indenting this retina, I I will not see this hole, as you can see. You can see this hole. So I'm searching for it and finding it, trimming the vitreous over this hole. Very meticulous, removing all vitreous over this hole. Again, diathermy this hole to be visualized when I do fluid air exchange. This is a very small hole. So don't be confident that when you found your first hole that you are in a safe zone. Please keep searching for another hole, second hole, third hole, fourth hole. I do a direct fluid air exchange, make a technique of fistel to put the primary brake on in most dependent part. Don't use a BFO. Now, totally, in 100% of my cases, I drain from the primary brake. Lasering 360. In this case like this, if I found a 1 or 2, 3 breaks, I do a 360. If I have a 1 only break, I didn't do a 360. I do only a break, a laser around the break. If I feel that the posterior pole there is a small subretinal fluid, I don't care. It will be gone away after 1 day. Leave 100% of my primary rheumatoid retinal detachment cases on SF6. I didn't use silicone in my primary case. Never used silicone in my primary case. 100% I use SF6, and that's it, Dr. Ahmed. This is my case.
Mohammed, thank you so much for abiding with time. Actually, you're even ahead of the time, so thank you so much. And this is actually a beautiful surgery. And thank you so much. Wonderful. I've got only 20 questions for you. So Mohammed, you mentioned that usually you don't stain because usually by definition, when you have horseshoe tears, there's hyaloid separation, right? But as you said, in myopic, especially you may have. So maybe again for junior doctors, it's best to use a bit of some Kenalog, but just use a little bit.
I think for junior doctors, you need to stain. Whatever the type of patient, I need you stain because your visualization about the vitreous is not like if you are using, if are you doing much more surgery. So, and if you're starting your vitreoretinal surgeon, usually stain from the first step of surgery. Usually stain your vitreous.
Okay, then my second question is, and again, my little tip here is to put a little bit of Kenalog because usually I keep shooting myself in the foot, putting too much Kenalog. So just a little bit of diluted Kenalog. So, okay, the second point is we've seen beautiful laser. And you've mentioned about the focal versus 360. So, does anyone of the panel do just focal laser?
As possible as I can, yes.
So, Wael and Abdallah and me as well, I only do focal laser. 360 usually if I cannot find the break. And Ahmed Habib, do you do 360 laser?
Yes, I do. 360
it makes it sleep better.
Yes.
And what's happening in Asyut?
So
the
360 I usually do.
You can do 360.
Yeah, Ahmed, continue, please.
Yes, I used to do 360 degrees with a heavy laser. Nowadays it's just gray laser, but still 360 because the heavy laser would do some paralysis of the iris paralysis and sometimes the corneal insensitivity.
Yeah. So you do heavy laser or not anymore?
No. Just gray. Just gray. Still 360.
When you're gonna tell us more about what's happening in Asyut?
It's the same like Ahmed, just mild laser and avoid 3 and 9 o'clock. I think it's not like previously, you do a whitening and heavy laser. You just do a barrage like in the periphery and with just faint laser and avoiding 3 and 9 o'clock.
Okay, that's very good.
I sometimes use also cryo in these cases, especially if there's only like 2 or 3 breaks. Cryo works really well, just gentle cryo, and it's very nice, especially if the eye is faded and the break is very anterior.
Abdallah, that's a great point. I do that as well. This is the way the classic teaching in the UK. Cryo solves the problem. If it's 1 or 2 tears, especially if you're working alone, it's cheap. It doesn't need to be dry, and 1 or 2 break is not going to cause any problem. So we'll move to tamponade, and a question here from. So maybe before moving to tamponade, the diathermy, just to mark the break, just be wary. Diathermy shrinks the retina, so maybe just a little mark so you can see it. And I would encourage you, as Dr. Tawfiq said, always to mark, especially at the beginning. And I still mark because I don't want to go back again.
That's just enough to do a point, like one mark, not 360.
Yeah, because it does shrink the retina.
Yeah.
So we have a great question here from Dr. Higazi. Thank you so much for joining us, and we're waiting for all your tips. So, Tawfiq, do you use gas even if it's a lower break?
Yes, 100%. I give the patient the first chance to put the eye on gas, and I found in my hand 90 to 95% of patient will be flat. This is from my surgery.
Okay.
I think no role for silicone in primary vitreoretinal.
Yeah, thank you so much. And I love a comment made by Mustafa yesterday, where he said, actually, in primary surgery, we try to do a minimal surgery. And that's really what I think Abdullah and I do, and would be really good to hear about what's the other are doing as well. But whatever you do, the single operation success rate is in the 80%. So whatever you do, so I would say keep it simple, because it works with pneumatic, it works with buccal. You don't need to be aggressive. That's again my personal view. I know Abdullah concurs as well. So we'll hear from other panel. Well, Ois, yes, please.
I think the use of chandelier enables, as Dr. Muhammad showed, he had a wonderful self-control over the indentation, and this makes the laser less risky and more punctual. He did a wonderful laser around the break. I think the cryo, even though it is of course a classic teaching and it is less invasive, but there is also a risk of dispersion of retinal pigment even in an air-filled globe. The laser marks now can be done perfectly. He could indent perfectly in his technique because of the chandelier. He could indent perfectly, and the retina was completely attached to the underlying retina pigment. He could do a perfect laser. So I think I don't like to go for a cryo now in the retina attachment.
Yeah, but well, there's several points. I mean, like Muhammad is he's a well-established surgeon. If you read at the beginning, things are difficult to get that beautiful view, especially under air. The other thing is, if you have an IOL, the capsule is open, especially if this patient happens to have a silicone lens, it's pain really. The view is very bad. And that's where if you have a one break, a cryo is very helpful. Or phakic patient, as Abdullah said, where you actually is difficult to reach, especially if you don't have the luxury of chandelier. So I think don't exclude cryo, especially for beginning surgeons. And it's just, if it's only like 1 or 2 tears, cryo can be very helpful. That's again a personal view. And okay, let's talk more about tamponade. So we heard gas from me, Abdullah, and Muhammad Tawfiq. Habib, what do you do for tamponade?
So I have an imaginary line between 5 and 7. Below that, I use silicone. Above that, I do gas. I think I also have some considerations about the patients. If the patient is far away, he cannot get to me in time, I will put silicone. If the patient could not enter the operation the next day because of any systemic problems or so, I also put silicone, because the silicone, if in recurrence, it gives you time to prepare the patient. But if the recurrence happens under gas, you have to enter in a day or two at the most, because the dispersion of the PVR would be, in my opinion, catastrophic.
Well, Suleiman, what do you feel?
I'm a little bit classic, like Ahmed Habib, above
Classic
5 and
means
7.
gas, right? Classic means gas? Or?
No, classic silicon.
Oh, wait, so
Because
classic
yes, because above 5 and 7 o'clock, I can put gas only if the patient is educated and he will follow my instructions, and also he is accepting to open his eyes in the morning and accepting that he is not seeing for 15 days or 3 weeks. But most of our patients in Upper Egypt, he is very frightened and he likes to see in the next day of the surgery, even if it's a little bit blurry of the silicon. But I can tell you that 70 to 90% of our patients here in Upper Egypt like to see in the next day. So also they are coming from a little bit far away. So as Habib said, you need to follow them. And if they detach it under gas, for me, it's not good. So again, I am following the rules of upper tiers gas if the patient is educated and accepted not to see in the second day of the operation.
Right, thank you. And lastly, while I wait on this, gas or oil?
Well, I think my critical point is not the number of the breaks or the location of breaks. The critical point for me is the detection of early signs of PVR in the periphery. In the case of Dr. Muhammad Tawfiq, it was clear that it is a fresh detachment and there was no sign of PVR. In these cases, of course, gas would be my choice, whether it is an inferior break, whether it is multiple break. But maybe I have my sensor a little bit more in action. If I see patients who are candidates for PVR or who are liable to have PVR, like multiple breaks is a factor for me. But if I find during the surgery that I had the retina completely reattached under air, the oral space is very clear why it's reattached. I don't find in this case that I would need silicone oil. However, if the retina is redundant or we see signs of vitreous contraction, you will see it in the periphery that the retina is not smoothly reattached. In this case, I would put silicone oil even if it is a single upper break.
Well, just to keep it simple, because again, remember, these signs can be subtle for you. What's your split?
Fresh detachment?
What's your split in fresh detachment?
Yes. A complicated detachment with early PVR or giant retinal tear, silicone oil.
No. So, okay, a case like what Muhammad shown, you would do a gas, right?
I would do a gas like Dr. Muhammad.
Okay, all right. So we got different opinions, but again, I would try to keep it simple. Whether you use oil or gas, and we can disagree till the morning about what's classic, is the gas or the oil. Abdullah, can we have a quick question from you, and then we need to move on?
Yeah, just one more comment. For inferior detachment, I usually use C2F6 rather than SF6. And for inferior break retinal detachment, I often try to make sure that the retina is dry on table. And I use C2F6, and I also encourage patients to sleep on their back for 2 or 3 hours immediately after the surgery to make sure that some sort of apposition has started before they go home.
Right. So, Abdullah, thank you. Question to Tawfiq from Dr. Nabil Harris. Thank you so much for joining us. So, why not PFO?
I never use the PFO.
So why?
Oh, for me, this is an extra step. For me, it's an extra step. Whatever you use the PFO, whatever you use direct, there is a small subretinal fluid present after removing the PFO. If you use the PFO or if you use the direct air, sure, the fluid persist after PFO is a little amount than the fluid persist after the direct fluid air exchange, but still there is a fluid under the macula. It will take a time to go just.
I think that was evidenced by intraoperative OCT once in a meeting.
So if I can say that you don't use PFO because an extra step, more time, also cost, and the best way to avoid problems with PFO is to use
It's a complication, Dr. Salam. The PFO have its own complications.
Yeah, and the best way to avoid them is to use it less. So can we have a show of hand of who uses PFO routinely in nearly every case of retinal detachment? Again, we're talking about primary detachment. Anyone use it routinely? Well, always, okay. Right, so so we have 2 ALs using the PFO, and then the rest of us are not using the PFO.
But I just wanted to say that you can try to do air fluid exchange, and if you find that you, as Tawfiq said, that the retina is you have minimum fluid under the macula when you do the fluid air exchange, it's okay. It's a good sign that you cannot use the perfluorocarbon. So we cannot generalize this idea on all cases. You should adapt to the case. If you have a bolus detachment and you put fluid air exchange and you still have a huge amount of fluid under the macula, I think you have to use PFO. So generalization is a little bit difficult in all cases. Well, this is only my comment.
No, I think this is a great question. This is a great comment. But I mean, in general, this is really what people do. Like, if you have like a really big fluid under the macula, the main worry is a macular fold. You may go back and use PFCL or draw a drainage retinotomy. One tip is not to
Have anybody seen macular fold before?
Yes, I've seen them. Yes. A good tip is not to drain over the disc, because once you go and drain over the disc, the fluid pulls backward. So if there's lots of fluid left behind, actually, especially with an upper break, don't go and drain over the disc, and you'll avoid pooling of the fluid at the macula. So the main risk of leaving fluid is macular fold, but this fluid you're worried about is going to be out of the eye in maybe like less than 24 hours.
And have also another.
Yes,
Dr. Ahmed, if you need to leave a small amount of subretinal fluid in a technique of direct fluid air exchange, make use this step of drainage from a primary break. Head positioning number 1, very gentle aspiration. Don't make your break dry early. Keep your the break open much as you can, and then to dry the break early. If you dry the break and the break is closed, you have no way to the fluid to go from this break. So for me, make this step with a fluid needle or by means of passive aspiration, not active aspiration, and take your time to dry all fluid from the primary break, and the break will not dry will dry after 90% of fluid will go.
That's a good point. Habib, please, yeah, go ahead.
After drying, if the break, the primary break dried up, and you still have some pooling of subretinal fluid, you can position the head of the patient and stay for a little bit for a little while, and you can use active aspiration to gently pull on one of the edges of the brick and pull a little bit, so you can elevate a little bit the edge of the brick and aspirate the subretinal fluid. I think this helps a lot.
Yes, so that's actually a good point. So we just want the junior doctors really with us now to just note all these points. You may not use them, but at least you need to understand what's happening. So leaving fluid in the eye under the retina, there are 2 problems. One problem is that you will have a less complete fill, which in my view, it doesn't matter much really. The other point, if it's too much fluid under the macula, you may have a macular fold, and we'll talk about positioning in a second to try to avoid a macular fold. Otherwise, then all this fluid will be gone, and it's a retinal detachment surgery rather than a retinal break surgery. Sorry, it's a retinal break surgery rather than a retinal detachment surgery. All the fluid will go away. So question here about using gas in all cases. I use gas in all cases. That's a question from Dr. Higazi. So We have another question to Dr. Tawfiq. If we're talking about minimal surgery, why not to do cryobuckle first? So just quickly, we're focusing on vitrectomy on this course, but what cases you do cryobuckle, Mohammed?
If it is a young patient, you do cryo. If it's not a young patient, you don't need to do cryo.
So okay,
it's a pseudophakic patient.
Yeah. So you do like the PVD detachment, right? The
it's not a decision primary vitrectomy or not. We agree if it's a young patient, phakic young patient, rheumatologic single break, the best way for him is buckle. If it's a pseudophakic primary vitrectomy, for me there is no rule of buckle in this case. Even if it's a macular on 6/6 patient, for me it's a vitrectomy is the choice. For me,
right. I'll speak about Abdallah's behalf because I know what he does. So young patients, myopic or dialysis, these get buckled, otherwise vitrectomy, right, Abdallah?
Yes.
Right, that's the classic teaching in the UK. So we have we need to talk a little bit about post-operative positioning. So we have a great comment here from Mustafa. So face down positioning in the first 24 hours will eliminate the risk of macular fold formation. And this is very debatable, and we can spend hours talking about that. Just quickly about positioning. Abdallah, what do you do?
Yeah, what I found very useful nowadays, I agree with yourself, try not to go to the disc.
Yes.
So leave some fluid on the disc because this fluid is tamponading the macula. And what I found very useful is to ask the patient to stay on the back for 2 or 3 hours. Theoretically, if you ask the patient to put face down for a few hours, this can be a little bit of a help because the gas will push all the fluid under the retina. But this is technically difficult, and sometimes the patient, when they finish the surgery, they tilt their head to the side, and sometimes moving them upside down at this maneuver itself can shift some fluid, inducing the fall. So it's you can do it the other way. Encourage the RBE bump. So encourage patient just sleep on the back 2 or 3 hours. This will help to absorb all the fluid. And the tip Dr. Tawfiq said is really useful regarding very slow aspiration of the subretinal fluid from the break. So I'll take at least 10-15 minutes draining the fluid under the retina when I drain from the break, very slow, even if I use 25 gauge for all retinal detachment, and the back flush is very slow. It takes time, but it gives you a chance to clear most of the fluid as much as you can.
Abdallah, thank you. That's a great tip. I do like Abdallah as well, and that's why we're friends. So, anything different with positioning to avoid macular hold? Habib, please.
No, I usually do the face down positioning. I would like to comment on what Dr. Abdallah said about the slow aspiration of fluid. I usually leave I don't drain the original viscid fluid at first. I do a fluid exchange for the viscid fluid. I always say this tip is very useful for me. If I drain the viscid fluid in the early steps of the operation, the normal infusion fluid gets under the retina and becomes flappy. But if you leave the viscid fluid under the retina until before the fluid exchange, and you do fluid exchange, the viscid fluid will go out of the break and will not let the normal fluid from the infusion go into the break. So you actually are flattening the retina before doing the FAX, and when you do FAX, the residual fluid will be minimal.
Very nice. So question about what fluid we use when we aspirate. I use just active suction, and I try to do it a little bit slower. Well, can we have very quick comments from everyone for the sake of time?
Yes, very quick. Just to confirm what Habib said. Last case I did it without perfluorocarbon. The best thing is to do first fluid exchange, and then incline the patient a little bit while doing air fluid exchange, so you will finish all the fluid after. So if you do both steps, fluid exchange and air fluid exchange, actually you will finish nearly all the subretinal fluid.
That's a very good point. So
and I did a slight inclination, slight inclination of the patient towards the side of the tear. It helps a lot.
So that's a great tip. Always tilt the brake down and just do it slowly. That's a very good tip. But again, very important to understand why we're draining the fluid, and it's about retinal brake rather than a retinal detachment surgery. So does anyone do passive exchange compared to active? So active. Okay.
I do passive exchange if I intended to drain from a primary brake. Okay. This is the only step I using passive aspiration. Otherwise, I usually do is aspiration from my active suction.
Good point. So question from Dr. Hanout here. What about posterior drainage retinotomy? Do you consider drainage retinotomy?
Yeah, sometimes the issue usually happens if the brake is very small and very anterior in phakic patients. Sometimes when you drain, the brake is closed and you still have some large amount of subretinal fluid. So I may consider a drainage retinotomy in that case, and it looks really nice. But whenever possible, if I can drain from the brake, I'll try to do that, even if I ended up doing another wave of fluid exchange and then, change back to fluid again, and then try to do the packs to encourage more fluid to come out from the main brake. If I couldn't, and I found some significant amount of subretinal fluid, I will do a drainage retinotomy.
Okay, any other comments?
Right. I'm not a bit of it.
You're not a bit of it. I don't like it as well, but I do it similar to what Abdallah says. We always drain from the brake, and then if there happens to be lots of fluid, especially if it's pooling backward, then I would do a drainage retinotomy. For the young people, the problem with the drainage retinotomy is that it collects fluid so quickly, so you may not be able to laser it quickly. Just any gentle laser on the drainage retinotomy will close it. So you don't need to be really aggressive with the laser. Just a little bit of marking will be fine. And some people, and I've done that sometimes, do not laser the drainage retinotomy. It's too posterior and it doesn't detach. But just be wary. Drain, get them ready with the laser, and then get out quickly with the drain and laser. Or if you're using a chandelier elegantly as Dr. Tawfiq, then you can have actually the passive suction and the laser in the same hand.
Actually, this is what I would do.
Yeah, okay. So that's what we'll do. But this is a little bit of a difficult technique for a beginner. So drain, and then quickly laser. Or you can do the drainage retinotomy a little bit further out and just cryo it. And that's as well an easy technique. So do it a little bit more peripheral in the same line of the brake and cryo it. And then some people don't like drainage retinotomy and they use PFCL. Okay, a quick question from everyone. So what do you think your single operation success rate in primary retinal detachment? I just want a number. So I'll start with Abdallah. Abdallah, what's your number? Single operation success rate.
As you know, I record all my retinal detachment.
Yeah, go for it, Abdallah. What's the number?
85%.
Okay, well.
Fresh detachment, 90%. PVR, 65%.
Okay, 90%. Okay, Habib, what's your single operation success rate? Just an estimate.
You consider the silicon?
No, we're considering primary detachment, whether you fill them with silicon or gas.
91.
91. Okay, Tawfiq, what's your primary? Just about.
Very precise, yeah. 95%.
I did calculate it.
95%, wow. And that's with gas, right?
Yes. Yes. Dr.
Wesley, man, just an estimate.
90%.
90%. So again, I do like Abdallah. We need to know our detachment rate. So mine is 80%. And if you look really across the big studies, and we published one of them from UK Ophthalmology National Data, and there's one that came out from America from 5 centers. It's actually 80%. So whatever you do, there's about 80%, 20%, or 2 out of 10 would fail. So that's why the advice is just to keep it simple.
Well, just a quick comment. Yeah, when we say 85%, this means all primary retinal detachment after
including giant breaks, yes.
Whether they have a BVR or they have multiple.
Yes.
Yeah, so all primary detachment success rate is.
Salam, before we switching to another topic, what I'm learning in last 2 weeks, 2 years, that the surgery assisted indentation is a critical step and tool in your primary surgery, in a primary vitrectomy for a primary retinal detachment and a primary retinal detachment. If you feel that a primary primary retinal detachment for a single break, it's a classic, very simple surgery, and you didn't need your bimanual hand, your two hands. You are don't do a right thing. Using your two hands in a simple surgery is fantastic, by rather than use your two hands in a very difficult surgery. You are using two hands in a simple surgery, you are get a perfect result. You are searching very nice by your hand. You are doing a laser very nice by your hand, not by the hand of your assistant. You are doing a fluid air exchange perfect. When you indent your break and aspirate from your break, you are searching perfect for another break. Please, my message here, try usually to use a chandelier and use a bimanual technique in vitrectomy of a primary detachment. This is my message.
It just might be a bit difficult for a beginner surgeon, but I mean, definitely you have more control. Who uses who uses chandelier routinely in primary detachment or a simple case? Well, and Tawfiq?
More cases, not only retinal.
All cases, all right, okay, even cataract surgery.
Well,
right. Okay, so we have a question.
I think shielded light could give you the same visualization like chandelier. A little bit shielded light. So you can, if you don't have access to chandelier, so use the shielded light, please.
Okay, so again, if we can go back to switching off mics if we're not talking because of the echoes. So question here, what's the incidence of redetachment after silicone oil removal? I don't use much silicone oil, but I think it might be between about 10 to 15%, as I recall from the literature. Well, Suleiman, I mean, you use oil. What do you do?
I use oil in 90% of my cases, and my success rate is a little bit 90% also of all cases.
So 90% counting the oil in or oil out?
So we can conclude that the retina
just a minute.
Will be redetached.
Okay.
I put silicone in 90% of my cases, and I have a primary success rate from the first time of removal of my silicone, 90%.
Okay, all right, we got so 10% failure rate, right?
Yes.
Okay, so that may answer
we need to move on.
Yeah, please.
That the retina will be redetached. It will be redetached even if we are putting gas or are putting silicone.
I mean, I feel the same as well, but I think it's a big debate. But I feel the same as well. The oil gas debate is a big debate. Okay, well, do you want to move with your? Do you want to do your intraocular foreign body here? I'm just worried about the time, so I want to make sure you have your presentation.
Yes, sure.
Please go ahead.
I will give how do I do my foreign bodies?
Yeah, go into the meat of things for the sake of time.
Yes, I always do anterior chamber exit of foreign body and iris shelf technique or capsule technique. The main idea is that you do your cataract surgery, and then you do a posterior capsulotomy, and then you hold your foreign body and just pass it from the posterior capsule, as you see here. So I do a posterior capsulotomy using the vitrector, using the cutter, and I just relax it on the iris, and then I take up my brace, and then I go to the main wound of my phaco or irrigation aspiration. I take it by any mean, by forceps or by magnet. So this is the main idea, and my presentation is divided into, so this is the cases that I remove my foreign body using a forceps. the same technique, posterior capsulotomy, and then holding by the forceps, go up and pass it through the posterior capsulotomy, leave it on the iris, and then take it easily by any mean, forceps or magnet. And then I put my IOL inside the bag or in the sulcus. The same here, foreign body but this case was soliphakic case, and then I passed the foreign body behind the IOL and I put it above the iris, and then I take it easily from above the iris through the previous wound of the case, because this case had extracapsular before. This is a very long foreign body, and then I'm holding the foreign body with the forceps. I make my posterior capsulotomy, and then I make my main incision, and I removed the foreign body, and I lasered and make a phaco. I made a laser for the site of impact on the retina. This is using a magnet, the same procedure by using the magnet, and then I put the foreign body on the iris, and then I remove the foreign body, if it's large, by forceps through the main one. Another case, also I put here, I have no capsule, so I put a retropupillary artisan to correct aphakia in this case. Also another case by magnet, the same, again, up, and I put it on the iris. And then I remove it by magnet, forceps, whatever you have in your hand. But you have to
let me stop you for a second. So it doesn't fall when you put it on the iris?
Sorry?
Did it ever fall when you put it on the iris? Does it fall or it doesn't fall?
Look, Ahmed, I did many cases. Yeah. I only have one fall during this journey of this technique, and I will show you a case at the end of the presentation. My presentation is about to finish.
Okay.
Okay? Okay, so it's the same magnet, and then keep it on the iris by magnet, you remove it. As you see, it's a reproducible technique, and you just remove it from a small opening in your main phaco or corneal incision. This case, I could use it if I don't have a forceps, or I don't have this. Here I can use it. As you see, the phaco probe. The cutter. The cutter. You can use the suction, the vacuum of the cutter to remove also the foreign body. So if you don't have forceps or you don't have a magnet, and if the foreign body is small enough, you can just hold it. And can you see here? You just hold it by the vacuum of the cutter and pass it through the posterior capsulotomy and put it here. Here the iris was dilated, so I just put it here on the capsule and I removed it. And then I implanted my lens in the back.
Let me just stop you for a second. I mean, the whole aim is we teach.
Okay.
So we'll give you a chance to finish the presentation. No worries. So, if you're teaching a junior doctor, what's the safest way you think about how to remove the foreign body? Is it the forceps or the cutter? What do you think?
Look, I always, while I was a resident doctor, I never find this foreign body forceps, and always it's not working.
Right.
And sometimes you have the magnet, but the magnet was very large, and recently you have this small magnet with different sizes. So Previously, I was using the magnet, and usually now I use the forceps, especially the crocodile forceps. And if I didn't find the crocodile forceps or the small magnet with different sizes, I can use the vacuum of the cutter.
Thank you, Wael. Yeah, please continue.
Okay. And here I can implant my IOL. This is, in this case, I also do the same maneuver. I made my posterior capsulotomy and holding by the vacuum of the cutter, as you see. And I put it on the iris and I remove it. So actually we have here 3 ways of removal: a forceps, a magnet, and the vacuum of the cutter. This is the case that you asked Dr. Salam. This is a case of falling of the foreign body while I am trying to remove it. I made by posterior capsulotomy, as you see here, and you can see here also the iris defect of the foreign body. Here I use a forceps. I take my foreign body, I put it in the iris. The mistake here was not the problem that it's falling from the iris, that the wound was a little bit smaller than the size of the foreign body. As you see here, now it's gone. And then I have to go posteriorly again, and I widen my phaco incision. I go again. So I made a small technique, but it is a little bit difficult in some cases, while I am afraid for the foreign body to fall again. That after I look at this big foreign body, I could have it with the vitrector, with the vitrectomy cutter, and then I implant my IOL before removing the foreign body as a shield. It's the same like when you have a ruptured posterior capsule and you're afraid that your nucleus will fall down. You implant before removing the foreign body. Another step which is important, when always you have a retinal touch with some vitreal incarceration, I always make ILM peeling with all cases of foreign body, intraocular foreign bodies. So I always concentrate, especially if I have a foreign body touch in the area of the macular area. I finished my presentation. Thank you very much.
Well, thank you so much. Beautiful technique. Sorry, we lost Habib, but he's back now. Okay, so well, question. So why do you think just putting it on the iris, it doesn't fall?
Because it doesn't fall with me.
Right. Okay. This is actually, it's a very interesting concept.
Look, Ahmed, previously I was doing the scleral removal of the foreign body.
No, I'm with you.
With me, it was not reproducible. I have many falling. I have to widen the sclera. I could not titrate. How much should I widen the sclera? And then I shifted to this technique long time ago. Really, I don't have falling, as you see. When I have one falling, it falls because of that I underestimated the size of the foreign body. Let's say that this technique is good for small and medium-sized foreign body. If I have a foreign body larger than diameter of larger than 5 millimeter, maybe it's difficult to remove it through this technique, because I always make by posterior capsulotomy 4 to 5 millimeter in diameter. Also, your anterior capsulotomy is the same. So for very huge foreign body, maybe it's not reproducible. But as you see, for very long cylinder, like the nails that we have, it was very difficult to remove it for me from the sclera. Actually, during the last 5 years, I used this technique usually, and I succeeded. I managed to remove all my foreign bodies that I faced with this technique.
Well, just my question is not about sacrificing the lens. That's what I do as well, but I shake hands and bring it out. My question is, why does it stick on the iris? It's just a very interesting concept.
Look, the foreign body always is not slippery, always have some notches. So, and the iris, as you see, the tissue of the iris, if you just put the foreign body on the iris, it will be stable on the iris.
Is this your brain idea, or?
Yes, this is my brain idea.
Right? I think you should publish it if you have not. It's a very interesting concept.
We are in a way to publish it.
Okay, I think it's very nice. It's just that the fact that it sticks on the iris. I'm sorry, we'll have to move on. So, Wael, if you have a very quick question, and Habib, if you can please load your presentation.
It is a quick comment. I think the stability of
your presentation.
The stability of the foreign iris depends on the least possible aggressive manipulation of the globe. I mean, the aggressive tilting of the globe and the aggressive manipulations make dislodge the foreign body. But once you put in mind that there is a foreign body on the iris, you will be very gentle. You will keep it.
By the way, Dr. Salam, since Dr. Wael showed us his technique 2 years ago, this is my usual technique to remove the intraocular foreign body.
I also sacrifice the lens, and I think it's more controlled than the sclerotomy. The problem with the sclerotomy as well, again, it's good to know the pros and cons, is that when you have a big sclerotomy and the foreign body falls, now there is hypotony in the eye, and manipulations become very difficult after that. When you have
one key point is that in the many invasive areas that we have, so we have to shift a little bit to working and removing the foreign body in a closed space, like you say. If you have a large sclerotomy, you have hypotony. So this is the main idea.
Maybe you can do it from a separate sclerotomy, and you close it and you suture it afterwards. That's what I do actually, and I can fashion the separate sclerotomy size, whatever I see fit.
I think it's a preference thing, but I think the excellent point really from Dr. Wael's talk is that it sticks to the iris. It's a very interesting concept, really, and it's very interesting and very innovative. Thank you so much, Wael. Do you give intraocular foreign body? Can we intravitreal injections with all intraocular foreign body? Can I just have a yes or no? Because we're running out of time. Routine intravitreal antibiotics? Yes?
No.
Anybody yes? Okay, me yes now. I've changed like 6 months ago, and I tend to put intravitreal foreign body, intravitreal antibiotics. Okay.
Mind that we're all using antibiotic infusion in the vitreous infusion during the vitrectomy itself.
But not intravitreal antibiotics bolus at the end. Okay, Ahmed, please go ahead. So we're moving now to dropped nucleus and dropped IOL. Ahmed, please go ahead. Yeah. Habib, go ahead.
I think, oh yeah.
Okay. So Dr. Khalid Hussein is asking about the shield for the macula. So Dr. Khalid, can you just make it more clear what are you after? What do you mean by the shield of the macula? Ahmed, please go ahead.
Okay.
You're on. We can see your presentation.
I guess he means that if the intraocular foreign body falls back on the macula, this may cause iatrogenic trauma to the macula.
To use PFCL, for example, PFCL was not shown to be better than not PFCL to protect the macula.
I didn't use a shield for the macula.
Pardon? You don't use a shield, right? Ahmed, yes, go ahead.
Yes, okay. Can you hear me well?
Yeah.
Can you hear me?
Yes, we can hear you, Ahmed. Please proceed.
Yeah. Okay. So that's a firstly, I do the trocar bevel at 10 degrees. I so as not to suture it after the end of the operation. Usually, I do it so beveled, and I always check the infusion and to see the metal shine of the infusion, and don't open it until then. Then I do the AC cleanup. Usually, enter from the temporal part first because it's more accessible, and then complete with the from the other side. Then I do assess the situation if it's half a nucleus or the whole nucleus. If it's more than half a nucleus, I usually use the fragmentome. If it's less, I assess the situation about the hardness of the nucleus. If it's not that hard, I can take it by the cutter, but I usually prefer the fragmentome. And then I usually do a core vitrectomy, a thorough core vitrectomy, but I don't insist on the PVD. Then I clear the path of the fragmentome to be perfectly clear of vitreous, then enlarge the sclerotomy and enter by the fragmentome, but not forcibly. I try to enlarge the sclerotomy so as to enter easily by the fragmentome. Here usually I increase the IOP and decrease the vacuum to about 100. And try to take it from the side, to take the nucleus from the side. It will fall lots of times, but I don't think this will harm the macula. And try not to be near to the fragment, to the retina, so as not to catch the posterior hyaloid vitreous and induce breaks. Then I do internal search. That's very important, to search for breaks and to search for small lens fragments that can be entangled in the vitreous base, so I can do a selective vitreous base shaving. Then I can then implant the three-piece lens. The trick here is to enter the leading haptic into the sulcus. If you enter in the right plane into the sulcus with the leading haptic, everything will be all right after that. Then I leave the trailing haptic outside, and I take it by the McPherson, and I place it into the sulcus, and I usually don't rotate. And then I close the only the sclerotomy of the fragmentome, the one which I enlarged, and I try not to suture the other sclerotomies. And if the eye is a little bit hypotenuse, I can inject some saline into to adjust the IOP. Let's move quickly to the IOL or to.
So Ahmed, let me ask you a few questions here. So during previous discussion, you said that it's very important to search the peripheral retina, especially after you introduce the.
That's the internal search. Yes.
You have a video on that, you were saying? No.
Yes, it's inside this video.
Okay, I'm sorry, I've missed that. I do apologize. So, do you find tears? What's the risk of retinal tears, do you think?
If the anterior segment surgeon have fished around a lot with the case before I got in, sometimes I find breaks, but I usually leave it on air. That's the internal search part that I was talking about.
Yeah.
To find.
I think the point I just want to illustrate for the anterior segment surgeons, if any is hearing us, when you drop the nucleus, just leave it. It's it's relatively easy to deal with it, and the patients will do very well.
And it's better to implant if you can, and leave it down, because I would not. I would like not to enter into the AC if it's been 2 or 3 days, because the AC would be hazy, and I wouldn't like to interrupt the equilibrium in the anterior segment.
Maybe just another point, if you will implant the anterior segment surgeon, please clear the lens material, because you don't want it becomes difficult. So clear the lens material. We have a course on PC rupture. It's on the page. If you look at how to clear the lens material and then put the lens, if you can capture it well and good, and put a suture in, this is the best case to hand for a retina surgeon, right?
Well, I'll just add.
Suture does not exist. Abdullah, I'm sorry. Go ahead if you have a quick question.
No, I'll just say the lens material or the lens fragment or the IOL, they never hurt the retina.
Yes.
I've never seen any retinal damage from drop, even a whole lens. They never damage the retina.
Yes.
So, yeah, Ahmed, please go ahead.
Yes, okay.
Let's talk about dropped IOL.
So the dropped IOL, I'm sorry for the quality of this video, but I find the surgery very illustrative. So if you can see, there are some hemorrhages. The anterior segment surgeon was aggressive in trying to salvage the situation, but the IOL dropped. So there is some hypotony, and usually here you can inject some saline from the paracentesis and increase the IOP and enter with the infusion. Then
So Ahmed is cutting off. So until he's back, we had a couple of questions. When you use the 20 fragmatome, yes, we need to increase the infusion pressure. I think Ahmed touched on that quickly. So we need to increase the infusion pressure. So personally, I go with like up to 35 with the infusion pressure to account for the mismatch between the aspiration and the infusion. And that was a question from Dr. Nabil Harris. Another question from Mustafa Hanout. Ahmed Habib, tell us when you're back. Another question for Dr. Hanout about PVD induction. So again, in previous discussion with Ahmed Habib, he said that he would leave the hyaloid intact, but then remove the vitreous, and then after that try the hyaloid separation. That's what he does. But Dr. You had a Dr. Whale.
No, I think you have to complete your job regarding the vitrectomy and completing your vitrectomy before entering the fragmatome, because the fragmatome, I think, it always the suction of the fragmatome, and if you have a vitreous inside, you will induce tears. I think peripheral tears. So what's the problem if you finish your vitrectomy before you entering your fragmatome?
I think the problem, and that's again, it's all like preference thing. The problem is sometimes the whole nucleus is actually preventing you from making the hyaloid separation. I think if you can get it, well and good. If you cannot get it, you have to clear at least the pulse of the fragmatome. But that's the debate here, is whether to remove the hyaloid before or not, especially if you cannot remove it because the nucleus is sitting down and you have to move it around. Any other view? But again, we can see Dr. Well's view on that. Dr. Tawfiq, yeah?
But I think for Dr. Salam, it depends if you are, for me, if I'm using vitrectomy probe, if it's a small lens dropped or a soft lens, I don't mind to attack the nucleus even before complete vitrectomy.
Yeah, but I think we're talking about introducing the fragmatome, Mohammed. Do you insist on making the hyaloid separation beforehand?
Introducing the fragmatome, for me, it's not 50 to 60%. You cannot remove all vitreous before you are attacking the whole lens. Because if you are insist to introduce the fragmatome, it's meaning that this lens is large or it's hard or it's something you need to use a fragmatome. So it's very difficult to complete separation of the posterior hyaloid. You just remove the vitreous around the membrane, around the nucleus, and complete the fragmatome, and then complete your surgery.
And I think the important point is also to, yes, as Dr. Higazi say, in the pulse of the fragmatome, you have to clear the vitreous. And I would use Kinalog. If you can remove the hyaloid at that point, really good. But if you can't, at least this area needs to be clear, and you need to be really wary that you stop if there's any vitreous there. Okay, we've lost Dr. Habib because of the signal. So,
but I think Dr. Salam, about the questions of protection of the macula, I think there is no rule for putting a PFO or a heron over the macula when you are doing the fragmatome or
yeah, it has been. It has been. I've never seen a nucleus falling on the macula causing problem.
You agree?
Which I forgot to ask you all about intraocular foreign body, and let's leave Dr. Wahid Suleiman till the end on this question because he was presenting on that. Have you ever seen a foreign body falling causing problems? Abdullah, can we have a yes or no answer?
Interestingly, we rarely see foreign bodies here. Actually, it's very
all right.
rare.
Well, do you see any foreign bodies falling, causing problems?
I think it's very difficult that it.
Wait a second.
Look at the era of the sclerotomy. If you are hardly pulling the foreign body against a narrow sclerotomy, you may see some injury of the retina. But if you are relaxedly just put it on the iris and it will fall again down, I don't think it will cause a problem on the retina.
Okay, so you've not seen problems falling, right?
No.
Well, Awais, have you seen problems falling of a foreign body falling? No?
Salam, put Habib back. It's on backstage. Habib will be now it's backstage.
Actually,
Well, have you seen problems falling, body falling?
I see problems because I pull it and I get it outside the eye. I don't
Okay. I've not seen problems as well, foreign bodies falling, but I think it may cause problems. I try not to get them to fall as well, but they do fall.
So where did it stop?
So Habib, a question to you here. We keep losing you. Do you float the nucleus on PFCL and aqueous through corneal incision? Some people
I never do that. I tried it once, and the anterior and the nucleus was caught into the meniscus between the PFC and the side wall of the eye, and I couldn't get it, and I had to remove the PFC. So I don't do it. I use the fragmentome in all my cases.
Okay, Ahmed, do you want to show us your last video?
IOL?
IOL?
So where did I stop? Where did
you stopped when you were saying IOL fell down, and then after that your connection fell down.
Okay. Okay. So it's all of it. So this
you have 2 minutes.
Yes, this case was the anterior segment surgeon was fishing around aggressively in this case.
We don't see your video. If you want to get your video.
Oh, okay. I'm sorry.
So we have a question until you get your video from Dr. Nabil Hayes. Why not to bring in the AC, protect the retina with PFO, and do a phaco? I mean, I think yes, that's a good technique as well. The problem is the meniscus and the lens can go to the periphery. But yeah, I've seen that done, and the people who do it beautifully. I think the problem is it entails the use of PFCL, but then the advantage is you're phacoing in the anti-chamber. And thank you so much. Yes, that's a good technique.
So, am I on?
Please.
Okay. So this case was the IOL fell down, and as you can see, the anterior segment surgeon tried aggressively to retrieve it, and there was hemorrhages and also hypotony. So I had to enter and inject some saline to secure the infusion. Then after that, you assess the situation. What kind of IOL is dropped? Is there lens matter, lens fragments, hemorrhages, and the vitreous status? Is there any retinal breaks? And then you also assess the anterior capsule to decide what's your plan. Would you get the IOL and put it back again, or exchange it? And then you remove the vitreous. You do also a thorough vitreous core vitrectomy and don't insist on the PVD, and then clear the path of the IOL extraction to be perfectly clear of vitreous. You just have to de-entangle the IOL from the vitreous, and when you see it moving or shimmering, that's the sign that it is free of vitreous. And then you go for the lens capture. According to the lens type, you take the IOL. If it's a one-piece IOL, you can take it from the haptic. But if it's a three-piece, I prefer to take it from the to catch it from the optic, because sometimes the haptic is brittle and you can tear it off. Here I'm positioning the IOL to catch it from the optic. Are you with me?
Yes, sir.
Yeah.
With you.
And then you take it up and you catch it I catch it with the hand shake technique with an all 20 gauge forceps from the sideboard. I release my right hand, the hand which was into the vitreous, and then by the same right hand I take I enter from the AC and position the lens in the AC, all of it. I take it out, all of it into the AC, and then reimplant it into the sulcus, or you can remove it if you're not sure about the anterior capsule. You can remove it and insert an anterior chamber or posterior chamber upside down iris glow lens, or a sclera fixated IOL, sclera fixation IOL by a main technique or any other technique. Then you go to the lens matter. Then you enter again, remove the lens matter if there is any lens matter left, and do internal search, and you finish up the operation.
Ahmed, thank you so much. So I think just for, again, the junior doctors hearing us, remember the internal search. It's very important, and make this as a routine. In every vitrectomy case, you do internal search before exiting the eye or before putting a tamponade. I was meant to present on diabetic vitrectomy, hemorrhage, but I think we're running out of time. So let me show a very quick video on removal of the drop lens fragment, and then after that, I'll get my resident to show the technique we use, or he uses, in doing combined vitrectomy.
So do you do PVD, all of you, or like me, just do a thorough core vitrectomy?
So I think what we agreed on is, or what we discussed is, we try to do hyaloid separation even before the fragmentome. If we cannot, then we postpone this after the fragmentome. Dr. Whale is saying he always does it before. It's just sometimes difficult. I always try it. But if it's I keep trying and it fails, then I just leave it, really. I try not to challenge nature, but I always try to remove the hyaloid if I can.
But after finishing the procedure, you remove the whole vitreous, I think. You have to do after finishing the lens or removing the IOL. Do you leave the vitreous or you do BVD?
I try to remove the whole vitreous. I try to do PVD, but then if I cannot re-induce a PVD, and I tried, I would leave it. And that's in any case, whatever the case is. I may use PIC, but then if I'm not going anywhere, then I would just stop and leave it.
You will give up, yes.
But I try beforehand. So I think, let's see if any questions before.
Just one more comment. In cases of IOL, I always, or most of the cases, I use triamcinolone, and I try to trim all the vitreous all around, finish most of the steps of the surgery before taking the IOL to the front part of the eye, as much as I can.
I think that's a great point, Abdallah. Thank you so much. Make sure that the IOL is not attached with vitreous. Let it fall down and then take it out. It's much better than putting on it's much better than putting on the on vitreous. Okay.
Mustafa Hanout is asking if Aqueous is in Egypt. Yes, it's available in Egypt. Aqueous Bush and Dome lens.
And we have another. Thanks so much, Wade. And we have another question from Dr. Nabil Harris. Is it mandatory to do PVD and peripheral vitrectomy in dropped IOL? I think it's better. It's better to clear things. It's good to remove the hyaloid. But again, if things are difficult and you cannot do it, then I would leave it. Okay. So here, this is just something you may find interesting. This is a patient with dropped nucleus. Can you see my video?
No.
Okay. Sorry. Okay. All right. Let me. Can you see it now?
Okay.
Yes.
Yeah. Okay. Thank you so much. So here. The lens was, so this is the question we were talking about. So I put hyaloid. I was removing here the whole vitreous, and I managed to get the hyaloid separation as well. And it's very important to clear well before introducing the fragmentome. So here I'm using an Ozil tip, the phaco tip from the limbus. It's a little bit tricky because of the angle, but the aim is to try to catch it, get it in the mid-vitreous cavity, and then keep rotating. And this is 4 speed, but this is actually the whole time. But this is 4 times speed. And that's the 3D.
Working. The video is not working.
Video is not working? I'm sorry. I do apologize. Let me just do it one more. Thank you, Abdullah.
Thank you.
Okay, is it working now?
Yes.
Yes.
Okay, so the nucleus was attached. I induced hyaloid separation, and I'm cutting to get the nucleus to fall down so I can remove it without vitreous. And you can see a point of hemorrhage there, and that's why it's important to do internal research. Now I'm introducing the fragmatome. This is actually an ozzle tip through the limbus. The angle of attack is a little bit difficult, but you need to just suck it and come in the center. And this is 4 times, it's the full video, but 4 times speed. And I'm using about 200 vacuum and 10 ultrasound. And every time you pick it up and you stay in the center, away from the vitreous. And using a high vacuum and little ultrasound makes the tree continue to attach to the tip. And that's the full video, just 4 times speed. So the trick really is vacuum and very little ultrasound so it doesn't chatter. And I think the question you're going to ask me is the cornea burn, right? So then in the next slide here, you can see that the cornea looks fine. It doesn't burn. Again, I think that might be difficult in the beginning, but that's something as you get more advanced with junior doctors that you can try. And the aim is to catch the nucleus and get in the middle vitreous cavity. Right, I think we're running out of time, so we'll leave the diabetic to another session. I hope we get another session. And now I will very shortly let's get some questions, and I'll get my my resident to present the combined vitrectomy. So any questions that we have here? We have a bit of a hard nucleus crushing between the instruments and the vacuum. Does that work? Yes.
Well, there is no harm for the main wound of the cornea about this fragmatome if you are entering this
if you remember in the era of like many years back, maybe 10 years back, there was this era of micro incision cataract surgery, and that's what they were doing. And they did not burn the cornea.
That's perfect.
Dr. Salam?
Yes, please.
For the question of Dalia, Dr. Dalia, to use the light to fragment the lens, yes, this is a feasible technique. If you use a bullet light, which is a little bit triangular from the tip and a little bit sharp, you can use your light as a chopper inside the eye and fragment the lens to small pieces and finish your job nearly by the cutter, the vitrectomy cutter.
Yeah, I wouldn't advise that. And I think Always beautifully showed a video before on that. The problem is you will do it, but it will take ages. And it's much easier to use the fragmatome. Again, that's a personal view. So we have one.
Yes, the fragmatome, you finish the lens drop easily and with short time, but you have to widen a little bit the sclerotomy. But if it's a little bit soft lens, you can finish it easily with your vitrectomy cutter.
Yeah, and I think that's what Dr. Habib showed. We're all in agreement. So, Always, you have a comment on that.
Well, this is one of the bimanual techniques that I perform. I mean, with one hand, I hold the vitrectomy probe, and with the other hand, I use a pick, a fashion pick, which I use as a chop. I give the chance in the beginning for the vitrectomy probe, and it is very smooth in so many of the relatively soft and moderate density cataracts. It can be chopped, broken down, fragmented into small pieces that can be engulfed with the vitrectomy probe using a high vac, low cutting rate. You can get it in many cases, and it can be done without having to enlarge the sclerotomy and to insert a fragment. So I think
Yeah,
this
well,
is
thank you so much. So I think to sum up on that, we'll, two options. A fragmatome is much quicker. If it's soft cataract, definitely you don't need a fragmatome. So Dr. Tawfiq was very kind to come out. Thank you so much, Mohammed. Okay, and he's kindly in the backstage so that we can get Dr. Chancellor. Dr. Chancellor is our senior resident, and he's going for a fellowship in Baylor, and he will show his technique for combined vitrectomy. John, hi. Thank you so much for joining, and we all know that you speak good Arabic, right? John, can you hear us? John, can you hear me? Can you show your presentation, John?
I think he needs to unmute his...
John, can you unmute? Unmute.
I think he's muting the computer itself.
maybe yes.
I'm sorry. Okay, can we have more questions, maybe?
Hey.
Yeah, the other...
I can't hear you. You have to...
I wasn't talking yet. Can you guys hear me now?
Oh, yeah.
Yes. Okay. So, John, hi. Can you present your technique for the vitrectomy, for the combined cataract vitrectomy?
He's not hearing us, I think.
I don't think he's hearing us. Okay, let's get... So we have a question. We have a question about... I don't irrigate, Mustafa, I don't irrigate the ozzle tip. It doesn't burn the cornea.
Yeah, the other option, we have, I use the 23 gauge fragmatome, and it works really well, even if with the hardest cases. It works really well. The only tip is that you need to increase the infusion a little bit. So at least, I normally use 25 gauge vitrectomy for these cases. So I take one of the trokers, make a 23 gauge port, and use a 23 gauge fragmatome. But I increase the infusion 35 to 40 to account for the high vacuum count from the different sclerotomy size. Yeah, they are there. Yeah, I guess, Ahmed, we can see the video now. I think, John, you can go ahead. Yeah, John, please go ahead.
John, go ahead.
Okay, can everyone hear me?
Yes, we can hear you. And again, to introduce John again, he's our senior resident. He does all the cataracts with combined vitrectomy. He's a great surgeon. He's going to a fellowship for Baylor. John, go ahead.
Sure. Thank you very much, everyone, for having me. Those are some great videos so far. As a young surgeon, very helpful for me as well. I've done about 150, 160 cataracts, so I'm also a beginning cataract surgeon. And so I wanted to go over a couple of tips. I've been working with Dr. Salam in performing combined cataract and vitrectomy. So the basic principles I wanted to go over are kind of from the start of the case to the end of the case. Certainly, we always insist on placing the trocars before you make any of the cataract wounds. This is because once you've made the cataract wounds, the eye becomes even more soft than usual. As you can see, this is an eye with a Ahmed tube shunt already. And so to have made the wounds before the trocars would make it very difficult to place it in a soft eye. Principle number 2, we recommend creating a much smaller than usual capsular rhexis, so recommend 5.0 millimeters. This is designed to make sure the intraocular lens remains stable during the vitrectomy and during the air fluid exchange and other steps of the surgery. Basic principle 3, as far as nuclear removal goes, Many of these patients are young diabetics in their 20s and 30s, so they have very soft lenses. In the case of a soft cataract, which I'll show shortly, we recommend using single instrument aspiration and phacoemulsification. It allows the case to proceed very quickly and efficiently and minimizes any irritation of the iris or the cornea. With harder cataracts, we would recommend dividing the lens inside the capsular bag with your preferred technique, whether that be sculpting or cracking or chopping. We recommend getting the pieces divided in the bag and then emulsifying small pieces at the iris plane. The reason for this is it avoids iris manipulation and corneal edema, which can become difficult problems later in the vitrectomy. Another basic principle we use is instead of removing the viscoelastic, we actually fill the eye with cohesive viscoelastic, such as Provisc, prior to inserting the trocar and performing the vitrectomy. This eliminates the need for a corneal suture, and we can remove this later in the case. Of course, at the end of the case, you do want to remove all this cohesive viscoelastic to prevent any pressure issues. However, when you do this, it's very important to turn off the posterior infusion. Otherwise, this will result in the lens prolapsing forward and can lead to other problems with the case, iris prolapsing out of the wound and other things. So I wanted to show a quick little video of us performing a cataract prior to vitrectomy surgery. So here we go. Can everyone see the video?
Yes.
Yes.
Yeah.
Dr. Salam, do you have the video on my screen?
Yes, you are on. Proceed, Dr. John.
I'm not hearing anybody if people are talking.
Press play, please.
It's okay. It's okay.
But I can't hear anybody, but I guess I'll play the video here. So,
John, you're good.
okay. So as you can see, we've got the trocars in the eye prior to starting any of the cataract wounds. This is a young patient, about 33 years old, very bad type 1 diabetic with combined tractional rhegmatogenous retinal detachment. Expected to be a very long case, 4+ hours of vitrectomy was undertook. So we planned to sacrifice the lens because we knew it probably wouldn't last through the whole case. So we've already got the trocars in the eye, making side port, kind of a limbal side port incision with the nicking the limbal blood vessels. Then we like to use a mixture of epinephrine and lidocaine. It helps perform pupil dilation and provide anesthesia, although this patient was asleep. And then inject a viscoelastic. Again, we use a uniplanar main incision. This seals well and is able to maintain the chamber well. Performing the opening the anterior capsule with a cystotome. And you can see there we have the overlay system, which kind of allows you to plan out your 5.0 millimeter rhexis. So we'll get the capsule open and then perform the capsulotomy with Utrata forceps. While doing the capsulotomy, it's very important. We kind of like to start at the 3 o'clock position and work our way around. And anytime the tail starts to become long, you move it to the center and keep it out of the way so that you can continue performing the rhexis without having the tail in your way and obscuring your view of the leading edge. As you can see here, coming around, again, moving the tail out of the way towards the center of the eye. And there's a clear view where you can just grab and finish off. This is all in real time, unedited. So now we'll perform hydrodissection. We know it's a very soft lens, so we're going to prolapse the distal end slightly above the capsular bag. And for phacoemulsification, we'll go with the port down, and we start by aspirating the distal end of the nucleus. This causes the nucleus to flip up into the anterior chamber and allows for easy emulsification. By not putting a second instrument in the side port wound, it allows the fluidics to be maintained and keeps the posterior capsule far away from the lens and the phaco handpiece. Again, you can see we're just keeping the handpiece in the center of the eye, occasionally moving to regrasp the nucleus and move it directly to the center of the eye at the iris plane, and using mostly aspiration with a little bit of phaco power to emulsify the nucleus. Again, that was all in real time, about 2 minutes into the case, and now just showing the end of cortical cleanup and polishing. Insertion of the one-piece intraocular lens in the bag. And then you'll see we inject some more cohesive viscoelastic right here to maintain the anterior chamber. And then we're able to put the infusion in and perform the vitrectomy. So again, just to kind of summarize the points, some basic principles: make sure you place the trocars before making any cataract wounds. create a small 5mm rexus to allow for stability of the intraocular lens. For soft cataracts, we recommend single instrument technique. For harder cataracts, divide the lens inside the bag with your own preferred technique. After insertion of the intraocular lens, we recommend filling the anterior chamber with a cohesive viscoelastic. This eliminates the need for a corneal suture. And of course, you have to remove the viscoelastic at the end of the case and make sure you turn off the posterior infusion while you're doing that to prevent prolapse of the lens or any iris out of the wound. All right, thank you. I'm not sure if we had any questions during this. Certainly, Dr. Salam's been doing a great job moderating and can help answer any questions that may come up.
John, we have two questions. One of can you hear me, John?
He's not hearing you.
You cannot hear me, John? No. Okay, John, thank you so much. Seems you cannot hear me. John,
on the private chat.
Okay, I think it's fine. I mean, he did a great job. Let me
Pardon?
Can you hear me, John?
Thank you.
Can you hear me? No? Okay. All right, John, thank you so much.
My connection's a little slow, so Dr. Salam, if you see questions and want to answer those.
Okay, all right, I'll do that. So, Abdullah, go ahead, please. You had a question.
Yeah, actually, I'm not sure. Did he mention that he leaves the viscoelastic and he removes it?
So we do one of two things. We either leave the viscoelastic in, then we don't put a suture, or we remove the viscoelastic and we put a suture in. We've been doing that. Easier when junior residents or like when residents operate with me is leaving the viscoelastic, then come and remove it later on. But the main point which John emphasized really, and it's very, very important, is if you do that and you come and wash the viscoelastic at the end, switch off the posterior infusion. Otherwise, everything is going to be in your face when you're doing the irrigation aspiration. We have a question here. Do we remove all cataracts in diabetic patients? No, only when there's significant cataract or in the difficult cases where we think this case is going to go over 3 or 4 hours. Then the lens becomes cloudy. Then we usually remove it. Otherwise, we don't remove it. Okay. John, thank you so much. We appreciate all your help.
Oh, I'm in mute.
Yeah, I don't know what's wrong happening. Let me
bring Dr. Wael, can you bring Dr. Wael?
Yeah, I will. To finalize, we will do that. John.
But I have a comment about the phaco vitrectomy.
Please go ahead, Mohammed. Go ahead as we get to Dr. Wael.
For me, I have 4 or 5 points in phaco vitrectomy. I complete all my step of phaco surgery before entering in a posterior segment, whatever, any trocars. I didn't fill the ACU with any cohesive or viscoelastic. I didn't use suturing anymore. Do your phaco surgery as at the phaco surgery, but very cautious about to be as a straightforward and the rexes 4 to 5 millimeter, because the size of the rexes for me, anterior rexes, sizes of rexes for me is a much more important in phaco vitrectomy, because if you have a wide anterior capsule, you don't have a support for the optic when you do oil fluid exchange. After finishing my surgery, is 100% of my cases, I put a dexamethasone in the EC 0.1.2 dexamethasone to avoid a postoperative inflammatory reaction or test in the ECU. It makes my cases of phaco vitrectomy going well. But what we are seeing is also it's applicable to put your 3 trocars and to leave your ACU with a Heron or viscoelastic. But for me now, I didn't use any more of this techniques.
Thank you, Mohammed, so much. So we have a few questions. We're about to finalize. We have a few questions here. How do you manage IOL haze during vitrectomy with the FAX? The issue really is, Abdullah, can you answer that? How do you manage the FAX during FAX, and you get a haziness with the because of the lens? If the capsule is open, you may get fogging behind the lens. How do you manage that?
So if you did posterior capsulectomy during the surgery due to one or more reason, and you try to do FAX, you usually get the fogging of the lens. So you can easily try to inject some viscoelastic coating of the back of the lens that will clear it. And or you try to inject some BSS squirt some BSS on the back of the lens. But in my hands, you just inject some viscoelastic.
Yeah, so Ahmed Habib is saying a little bit of viscoelastic and wipe it off.
Yeah.
Wipe the cataract.
Without the viscoelastic either.
You can just wipe it off.
You can swipe the condensation over from behind the lens. Oh.
Okay. Yeah, that's a good point. I got you, John, here with social distancing.
Hello, yes.
As you can see.
He gets the faster internet in his office than I do.
Yes, true. Okay, John, last question. We'll leave this question for you and then we finalize. Thank you so much for joining us. I know you speak good Arabic now. A question is, should the viscoelastic be removed before switching to air?
That's a great question.
What's the great answer?
Have we agreed on an answer?
Yeah, we have.
Yeah.
So now we're filling the eye with fluid. We're going to do a fluid air exchange. Would we remove the viscoelastic after putting the air in or before putting the air in?
Before we put the air in.
Yeah, this is a very important point. So before you put the air in, it's best to sort out all the anterior segment. That's what I keep telling John. Before putting air, sort out all the anterior segment, remove the viscoelastic. Make sure you switch off the infusion as you do that. Then you do the FAX. Final comment from Dr. Wael Awais.
Actually, I prefer to remove the viscoelastic at the end of the fig, and I place a suture.
We mentioned that. That's another way of doing it. Remove the viscoelastic and put a suture in, which is a good way as well of doing things. Yeah, no, I'm with you. But if you leave the viscoelastic before the exchange. Well, thank you so much. I think I tried that we don't run out of time, but even with me not doing the full presentation, we ran out of time. Very interesting. But I hope it was a good discussion. And I would like to thank you all, Dr. Wael Suleiman from Asyut and Dr. Abdullah Laban from Hull, UK, and from Dr. Tawfiq and Dr. Habib from Egypt, and Dr. Wael Awais from Cairo, Egypt as well, and Dr. John Chancellor from Arkansas. Thank you so much.
Thank you.
Thank you.